72-year-old man with a history of heart failure and reduced ejection fraction comes to the office for follow-up. The patient reports no change in his chronic dyspnea on exertion, so shortness of breath with activity, but he says he's had a persistent, non-productive cough for the past 4 weeks. So the cough occurs during day and night, and he's not been able to get a restful sleep. The patient has had no fever, chills, night sweats, or loss of appetite. In the past year, he has had several hospitalizations due to decompensated heart failure. And then I had several admissions. And 6 months ago, he was treated with coronary stent for an episode of a non-ST elevation myocardial infarction. So he had a blocked blood vessel in his heart, and they went in, placed a stent, ballooned the artery open, and kept the blood flowing. Recent echocardiogram revealed an LVEF of 30%, so he does have, pretty significant disease. Patient's other medical problems include hypertension, hyperlipidemia, and osteoarthritis. He takes aspirin, ticagrelor, atorvastatin, furosemide, carvedilol, sacubitril, valsartan, and spironolactone. So like we were talking about for that goal-directed medical therapy right there, I mean, he's on the beta blocker, he's on the mineralocorticoid receptor antagonist, and he's on the ARNI, sacubitril. And he smoked half a pack of cigarettes daily for 10 years, but quit at age 40. So he's on a lot of medicines. Big thing for me is the fact that he is on this. And this is a known thing that can cause cough. It's, oh God, don't ask me. Bradykinin mediated cough reflex.
Yeah.
So that one's already a thing right there, right? So we're persistent non-productive cough. Like, are we thinking this is a medication side effect? Are we thinking this is uncontrolled heart failure? The difference between productive and non-productive, is he spitting up fluids? Is he spitting up phlegm? Or is this something that could be from one of the medications that he's on that has this as like a known side effect? So temperature is normal, blood pressure is a little low, but he is on a lot of antihypertensives. So for heart failure, I think that's okay. Pulse is regular, respirations are okay, and his pulse ox shows 96% on ambient air, so he's saturating fine. Weight is fine, unchanged from previous visits, so he's not super volume overloaded. One of the big things that we were tracking in the hospital, like we said with the previous heart failure question, is the amount of diuresis that you do, right? So a good question to ask is like, what's your normal weight? And then try to diurese the patient all the way back until they get to their normal weight, because otherwise the rest of the weight that they're on is just fluid. So his weight is unchanged, which means he's probably not holding on to that much free water. Physical exam shows normal nasal and oropharyngeal mucous membranes, so probably not like a respiratory tract infection. Poor dentition, okay. Normal jugular venous pressure, clear lungs, and a grade 2/6 systolic murmur at the left sternal border. Not really any red flags going on. Poor dentition could be due to a bunch of different reasons. Maybe, it's the classic one is like a 20 something year old woman who's like bulimic, so they're vomiting a lot, and they'll give poor dentition as like a giveaway for that. The abdomen is soft and non-tender, no hepatosplenomegaly, trace bilateral lower extremity pitting edema is present. So not 3+ like the other patient was, but trace. So I mean, all of this really is to say that his heart failure is actually pretty well controlled, right? He's not symptomatic, he's not requiring oxygen, right? He's not like super volume overloaded. Chest x-ray actually looks pretty good too. So which of the following is the most appropriate next step in the management of this patient? I mean, like I said, he's on a medication that is a very popular medication for heart failure, but the neprilysin inhibitor in the Entresto, the sacubitril, does have this as a known side effect. And I think the easiest thing right now is to discontinue sacubitril. Somebody says E, which I don't think is incorrect also, right? So poor dentition from chronic gastroesophageal reflux, right? He's making a lot of acid and that is refluxing. Prescribing a proton pump inhibitor to reduce that amount of acid probably makes sense in the context of this question. If they didn't say poor dentition, I don't think I would have considered E as an answer. But like the fact that they did kind of leads you astray, because I feel like that's not incorrect. But I think the next step, like the quickest thing to do first, would be to discontinue the sacubitril.
Yeah, 100%. Like things you have to think about too when doing that though is that PPIs or proton pump inhibitors are not entirely harmless, right? They change the pH of your stomach because they inhibit the acid production, right? and that can impact how medicines are absorbed. So I think primary care doctors historically have been very quick to just slap people on a PPI if they are having a cough or if they're having heartburn symptoms. It might not always be the best choice. And our gastroenterology colleagues have been constantly reminding us, stop the PPI, or don't prescribe the PPI, because people just set it and forget it, and it can be particularly problematic if that's the case. So I think in this case, it is a little bit, it can go both ways, right? The poor dentition could be, but you could say if they have normal mucous membranes, are they having acid reflux into those membranes that can cause inflammation or not? It's not a very precise measure, but it can make things a little bit more uncertain, right? And then you want to really try to lean more on the patient's symptoms. Are they having nocturnal cough? Is it worse when they're lying down? That could suggest the acid's coming up and being irritating. Or does it not matter if it's like daytime or nighttime, or if it's sitting or standing or lying down, then it could be more so because of the sacubitril, right?
Yeah, actually,
so
that's a good point, because it was during day and night too, right? Yeah. There you go. I'm just gonna
that probably
say
points more towards a.
Wow, 25% is a lot though, right?
Yeah.
Like that the fact that they said poor dentition, like even considering it as part of like vital information to give, that probably would have got me. But yeah, I mean, I think like easiest things being the simplest things, you'd rather, unless it's like a completely necessary like life-saving medication, like you'd probably discontinue the thing giving you a side effect before you try to add on something else to manage the side, or manage another part of it. But yeah, so sacubitril, valsartan, aka Entresto, great medicine. A lot of cardiologists will eventually try to get their patients on this for heart failure, but it does tank their blood pressure. It does have this as a side effect. Also, it's expensive.
Yes.
That's another one too. Like not all of your patients, like your Medicaid patient, is not going to be able to probably get on Entresto, but that's what you gotta talk to your social workers for, and somebody else who actually gets paid to learn the ins and outs of the American insurance system.
63-year-old man with diabetes is hospitalized with right foot methicillin-resistant Staphylococcus aureus osteomyelitis. Big mouthful right there, but basically what it means is MRSA is the abbreviation that you may have heard of. It's a antibiotic-resistant bacteria that's unfortunately becoming really, really common, especially in the hospitals, but also in the communities too. And that infection is complicated by sepsis, which is like a body-wide inflammatory response due to a severe infection that can be life-threatening, and respiratory failure. So their breathing is failing because of this body-wide infection. He spends 3 days in the ICU on mechanical ventilation, which is the breathing machine, but is now extubated and has resumed eating. Perfect. So he's got the tube out and he's able to eat again. He has generalized weakness, mild cough, and foot pain, understandably, because his foot is infected. The patient has no chest pain, abdominal pain, bleeding, or diarrhea. He has no prior history of pneumonia, heart failure, or coagulopathy, which is all good things to not have. His current medications include IV vancomycin, which is an antibiotic we give for MRSA for this particular bacteria, subcutaneous heparin, which is a blood thinner that we usually give to people as a protective measure to prevent blood clots from forming, short and long-acting subcutaneous insulin, and omeprazole. His vital signs are within normal limits. Okay, great. So it sounds like we got someone in the middle of a hospital admission. He's got a right foot infection. They give this to us straight up. They tell us his hospital course so far. He was in the weeds for a while, really ill in the ICU, but now he's better, which is great news. And they kind of just set us up for the next half of the question. What are they looking for? So they get blood tests as part of what we do routinely when we're giving patient medicines, and when they're in the hospital, especially, we check their blood count, we check their kidney function, and we check other blood tests as well. It looks like their creatinine is a little bit elevated, and the albumin is low, normally 3.5, and it's down by 1 full milligram per deciliter. And we check the coagulation profile for blood thinning because we're giving him a blood thinner, but that's normal, which is good. We're not overdoing things, so to speak. So which of the following should be strongly considered when transferring this patient out of the ICU to the medical floor? Probably more of a question for someone at the resident level, right? This might not be something we tell students, especially because it's not related to what we typically think about as medicine, right? It's more like the practical stuff. How do hospitals work? When do we get patients out? It's like that dispo that you might have heard about from your attendings or your residents. Where do patients go and how long will it take for them to get out of there, for example? When is it appropriate? When is it too early? When is it safe? Definitely something that saiken cares a lot about as both a hospitalist and potentially an administrator in the future, right? This is exactly what he cares about.
This is why we use the transfer order set, and you don't just move the patient.
Order reconciliation. You got to clean things up so things can move smoothly. All right. So what should we think about when patients are ready to get out of the ICU to the floor, which is the slang we use for the general hospital wards, like not the ICU, but where you typically go, for example, if you are hospitalized for something that's not life-threatening or acutely life-threatening. We stop proton pump inhibitor or the antacid. Should we give him some albumin because his albumin is low? Should we start oral diabetic medicines instead of the subcutaneous insulin? Should we switch his antibiotic from the IV to a pill? Or should we switch him off of the blood thinner, which is being injected into him under the skin, to like a mechanical massage device for his feet? What should we do? I think this one's pretty straightforward, but it's a little hard to explain. So I don't know if you have a better way to explain to everyone about what goes into this thought process. Yes, it's A.
So this has to do with stress ulcers, right? Because if you're not eating, again, because you're in the ICU and you've been intubated and, very critically ill, the common practice is to give every intubated patient a PPI. This reduces the amount of stomach acid that they're going to, produce, and it'll protect against like gastrointestinal ulcer formation, which I think like the number is pretty high, like higher than you'd expect. Like I think like maybe 30% or something, but I mean it's enough to become like common practice. So basically somebody who's not using their digestive tract, someone who's not eating, still producing stomach acid, at risk of getting an ulcer. But now the patient is extubated and resumed eating and they're not having any problems, right? They're not having any bleeding, diarrhea, they're not having like vomiting or whatever. So there really is no reason for the patient to be on a PPI anymore, right? It does mess up with absorption. It is not, it sounds like a good option for a lot of older patients just because, reflux is so common, but there are contraindications and there are, different problems and deficiencies that can result on just needlessly continuing a medication for no reason from the ICU. So yeah, definitely somebody who's already resumed eating and was only put on omeprazole in the ICU in a intubated setting does not need to be on omeprazole on the regular medical floor if they're already eating. Yeah, so I mean, definitely this is just a thing that, 89%, this is just a thing that you probably really only think of like in residency, right? Because when you're responsible for all the little minute details on like the transfer order and everything, like it's probably like the biggest thing that like red flags for you when you're trying to get somebody out of the ICU, begging the hospitalists to get them off of your ICU list so you can have one fewer patient to worry about. Incidence of bleeding in the ICU is approximately 1.5 to 8.5 patients in patients receiving ulcer prophylaxis versus 15% in those not receiving prophylaxis. 82-year-old nursing home resident with a history of hypertension and COPD is brought to the emergency department after 2 days of fever, cough, and lethargy. He was treated with acetaminophen at the nursing home, but was found to be very confused this morning. His oral intake has also been poor. His daily medications include lisinopril, hydrochlorothiazide, and tiotropium. He has never been hospitalized for a COPD exacerbation or pneumonia. At the nursing home, there have been 2 cases of mild febrile illness over the past 2 weeks. All right. So I think somebody in the YouTube chat said this too. Like, is this like a nursing home acquired infection? I mean, yeah, like sometimes these facilities really do not have the staffing or their money to keep these places great. So whenever you're looking at a patient coming in with like shortness of breath, fever, tiredness, you're worried about an infection, and they're also saying, oh yeah, by the way, our facilities also had a couple of other patients that were sick too, you're worried about a common infection there. So in the ED, he's ill-appearing and obtunded. Wow, so he's not doing too well, and he's like non-responsive and just kind of lying there. His temperature is 103, very high fever, blood pressure is getting lower, pulse is 68, and respirations are 26 a minute. So this guy is not looking great. He looks acutely ill. We got to make sure that he's getting better soon, or else he's going to end up in like that ICU setting too. Pulmonary exam is crackles in the left lung base. So thinking more of like a unilateral lobar pneumonia kind of pathology. I'm pretty sure I already know what it is. Bowel sounds are hyperactive and his abdomen is soft. No meningeal signs are present. All right, so we've got low hemoglobin, low hematocrit, pretty okay, but still low platelets. White blood cell count definitely elevated. Neutrophil count is definitely elevated too. Serum chemistry is hyponatremic, which I feel like is I feel like the test shouldn't have given you that. Potassium, okay. BUN creatinine, maybe a little dehydrated. I mean, you don't know what his baseline is, but so albumin, T-bill is a little elevated, and you're seeing a little transaminitis too. Chest X-ray reveals an ill-defined infiltrate at the left lung base. PIP-TAS and VANC are started empirically because the ER was like, hey, this guy meets sepsis criteria. Can you admit him for sepsis? And then I'm like, sepsis secondary to what? And they're like, sepsis. It's not my job. So Dr. Saiken admits the patient, and it just said sepsis. So he just continued the antibiotics, but the patient continues to deteriorate. And the repeat chest x-ray shows that progressive infiltrates with worsening left lower consolidation. So clearly I did not do my job well. I just kept the same broad spectrum antibiotics on thinking they would work, and lo and behold, they did not work. And his lower lobe consolidation, that pneumonia, has definitely gotten worse. This pneumonia is most likely Legionella. This is it can live in the water, I think. This bacteria can, and you usually see it in nursing homes, in like their air conditioning units or like their shared water dispenser units. Multiple residents can get sick. We started broad spectrum antibiotics, but they didn't work because the way that you want to treat Legionella pneumonia is with levofloxacin. Generally, you don't want to give, a fluoroquinolone to an 82-year-old, but clearly they're not doing well and they're not getting any better, and you need to use the correct antibiotic and the correct weapon to target the correct bacteria. So I'm going to say Legionella in the water supply and levofloxacin. Wow, whoa. Wait, people said
interesting.
oseltamivir, really? But it's literally screaming like even the hyponatremia too. How often have you ever actually seen Legionella pneumonia with the hyponatremia? Yeah, so it's the contaminated water supply.
76-year-old woman comes to the physician for routine follow-up. That's me. I'm the follow-up. She complains of frequent right knee pain and swelling that is relieved by daily naproxen, which is a medicine similar to ibuprofen or Advil Relief. It's an NSAID. She was offered knee replacement surgery for her severe osteoarthritis, but she refused. She was diagnosed with stable angina 5 years ago and has not undergone any coronary intervention that's like a stent or something to help open up or fix this kind of heart disease that we commonly call. She denies chest pain with mild exertion, but admits to occasional chest discomfort with moderate exertion, which can sometimes happen if you got a lot of cholesterol plaques in your heart. If you try to overwork your heart more than it can handle, you'll get pain and achiness, and you might feel out of breath or winded when that happens. Our other medical problems include atrial fibrillation, which is when the atria of the heart, the top two smaller compartments, don't beat in sync with each other and they kind of just vibrate instead. High blood pressure, high cholesterol, and diet-controlled type 2 diabetes. Her current medications include warfarin, which is like one of the oldest blood thinners that we've got, and her target INR is 2 to 3. She's on aspirin as well, low-dose aspirin, metoprolol, enalapril, and rosuvastatin. These are all medicines that help with heart disease and high blood pressure. 35-pack-year smoking history, not too great, but she quit smoking at some point in the past. Her blood pressure is a little high. Her heart rate is 80. Her pulse is 80, but irregular. BMI is 42, which is quite high. That's, I think, class 3 obesity, kind of just how we class it based on how heavy you are. And then we hear a murmur, a 2 out of 6 mesoscelic murmur at the left sternal border, which could be a sign of either a leaky valve or because of the atrial fibrillation that's making it difficult for her heart valves to close in sync with each other. Her lungs are clear, and the right knee, as we thought, because of the arthritis, is mildly swollen and tender. Creatinine for kidney function is good. High density lipoprotein, that's what we think of as the good cholesterol. If anyone remembers those old Cheerios commercials from like decades ago, that's what I tell patients. We saw the Cheerios commercials where it helps lower bad cholesterol. The LDL, the low density lipoprotein, is the bad cholesterol. And then the HDL is the good cholesterol, so to speak. Triglycerides are fats. And hemoglobin A1C is the test we use to look for diabetes, and the cutoff usually is 6.5 or higher is diabetes. And then if they have diabetes, usually we try to get them down to at least 7. We don't bring them all the way down because we're not that mean, but we don't have to, right? 7 usually is when we see that things are fairly well controlled. Which of the following medications would be most likely to benefit the patient? So if I see this patient in clinic, what would help them with their life in general the most? Would it be clopidogrel, which is one of the blood thinner medicines, the Clopey, gemfibrozil, which is a medicine to help out with high cholesterol, glyburide, which is a medicine to help out with diabetes, lansoprazole, which is a proton pump inhibitor to help out with acid reflux, or niacin, which is a B vitamin that can also sometimes help out with high cholesterol. Not very glamorous. It's not super exciting. It's not like the person who's in the ICU and is dying from a pneumonia or something, but kind of if I see someone for follow-up and they're kind of living life, how could I help with keeping them healthy instead of something bad happening? Kind of what primary care doctors do a lot all the time is how can we kind of optimize their health with a medicine or with a recommendation or a lab test or something like that. So I think the main things here that are important, she is quite overweight. Her BMI is 42. In terms of her blood tests, honestly, her blood tests look pretty okay. Her kidney function's okay. Her diabetes, her A1C is only slightly above her goal of 7, otherwise not too far away. And then her LDL, her bad cholesterol, 65 is actually really good. Her triglycerides are a little high, but hopefully, at least where I work, it's not. It would be considered increased or elevated. I think usually for that's like 125 or 140 or something like that.
160.
160. Okay.
So it's not terrible.
So in terms of, we have to probably do some test taking here. Gemfibrozil for high cholesterol, high triglycerides. I don't think so. I don't think she needs that. Proton pump inhibitor. That's something to think about, actually, and I'll get back to that about why. Glyburide for diabetes. Her diabetes is almost at her goal, and we actually don't usually use medicines like glyburide in older folks because it can be a risk for low blood sugar, which can be bad. It can cause people to pass out, or they might fall, or they might get dizzy. So we generally try to avoid glyburide, and her blood sugars are already so well controlled that we shouldn't go too hard with this. So I'm gonna say no to C as well. Niacin for high cholesterol. Again, her cholesterol is doing good, so I don't think we need E either. And then clopidogrel is a blood thinner, like an antiplatelet medicine that we usually do for particular kinds of heart disease, like if you have a stent or something. She has never needed a stent because she has not undergone that coronary intervention. She's already on a low dose aspirin for that. And plus she's already taking warfarin that can be quite strong. And if we give somebody all 3 of these blood thinner medicines together, the risk of bleeding increases dramatically.
I wrote in the chat, like, I think it's D, but the reason is really dumb. Like, I mean, it's not a diagnosis question. It's not a treatment question. I just think it's medication management because she takes a daily NSAID and she refused surgery for her osteoarthritis, right? So in a 76-year-old woman, I just don't want her to get like an ulcer from taking a daily naproxen. And that's why I give her lansoprazole. Like that, it's not great reasoning, but also none of the other answer choices make sense, right? Like you wouldn't treat hypertriglyceridemia with gemfibrozil, like you said, glyburide, not the correct option here. Niacin, I mean, that's, again, you use that as like an adjunct thing, but I mean, her cholesterol is like pretty well controlled, and like she doesn't really need Plavix, so it's like, I guess it is lansoprazole.
I'm surprised only 61% of people got it.
So she's already on all the right stuff, and everything else is controlled. Current guidelines recommend switching high or moderate risk patients to a selective COX-2 inhibitor, or combining NSAIDs with a PPI or misoprostol. Lansoprazole is approved in the US for prevention of NSAID-induced ulcers. Additionally, patients should take the lowest possible dose of NSAIDs. This high-risk patient should be placed on prophylaxis since she will likely require long-term NSAIDs for osteoarthritis. So she has osteoarthritis of the right knee. And osteoarthritis is going to be that sort of wear and tear arthritis. This is like the grinding of bone on bone, leading to a lot of degeneration of the joint itself. And in this patient, she has so much weight being carried on her knees, like her entire body with a BMI of 42, that she does have significant pain and significant degeneration from, living like this and having all of this weight, down on the joint space.